Good evening, everyone. Myself, Dr. Maneendra. Uh, Today, we are going to have a webinar as a part of scientific program which Yashoda Hospital is conducting, mainly for the DNB and IDCCM critical care students. Today's session will be on acute pancreatitis. To take us through, we have two eminent teachers, Dr. Sachin Chidrawar, who is HOD, Consultant Critical Care, Sunshine Kims Hospital, Secunderabad. Welcome, Sachin sir. And Dr. Saswati Sinha ma'am, who is Consultant Critical Care, Manipal Hospitals, Kolkata. So we have our students, Dr. Indra, who is a first year DNB student, and Dr. Pratyusha, who is our IDCCM student, who will be presenting a case of acute pancreatitis, whom we treated recently. So as they're going through the case, ma'am and sir, you can interrupt them also in between, and you can ask them questions, and we can see how we can move forward for the benefit of all the students who are going to attend the session.
Yeah, thanks, Maneendra.
Thank you.
Yeah, Dr. Indra and Pratyusha, you can start the case presentation.
Yes, sir. Good evening, sir. So, is the case a 46-year-old male patient presented with complaints of pain in upper abdomen for the past 1 day, associated with nausea. He had a sudden onset of pain in upper abdomen, which is severe in nature, radiating to the back. The pain doesn't aggravate or relieve with the change in any posture. There was no significant past history and personal history. He was a chronic alcohol intake present for the past 20 to 25 years. On general examination, he was conscious and oriented. There was no pallor, icterus clubbing, cyanosis, and lymphadenopathy. His heart rate was around 103 per minute and blood pressure around 110 by 70 mm of Hg. 95% saturation on room he is maintaining. On bedside ultrasound, there was fair LV systolic function, IVC around 1.6 centimeters with less than 50% collapsibility. Lungs has shown bilateral A profile with no free fluid in the abdomen. Systemic examination, GI system. On inspection, there is no distension of abdomen and no skin color changes over the abdomen. On palpation, it was soft and non-distended. Tenderness and guarding present at the epigastrium. On percussion, we noticed tympanic note was there and bowel sounds were present. Initial lab parameters, his HB was around 14 with the total counts 13,000 and platelets 329,000. His BUN was around 14 with serum creat of 0.91 and serum amylase and lipase were around, lipase was 3,900 and amylase 724. And his sugars were around 186 milligram per deciliter and his ABG values were
So Dr. Indra, so what is your working diagnosis? You want to?
He presented with the abdominal pain, sir, with the elevated lipase. We're thinking of acute pancreatitis. And ultrasound abdomen is showing a bulky pancreas with pancreatic fat stranding.
So if you did not have the investigations with you, say the investigations are still pending, because it takes a little bit of time for the reports to come back, right?
Yes,
so with your physical examination, what would be your differential diagnosis? Of course, pancreatitis will be one of the differentials. So what would be your differential diagnosis?
Presented with abdominal pain, ma'am. So one of the differential diagnosis could be diabetic ketoacidosis, any acute gastritis, intestinal.
Was he a diabetic? You said he had no comorbidities.
No, ma'am. Differential.
If he has no comorbidities, then why would he have diabetic ketoacidosis? Isn't it?
Yes,
Yes,
ma'am.
ma'am.
If he was a diabetic, you have also mentioned the HbA1c.
Yes, ma'am.
If he was diabetic, then yes, diabetic ketoacidosis. Also, just see his age, right?
Yes, ma'am.
He's in the 40s.
Yes,
Yes,
ma'am.
ma'am.
Very unusual that somebody will present with diabetic ketoacidosis, even if he was a diabetic. So you will have to keep those things in mind.
Okay.
Anything else you would want to consider in the differentials?
Acute cholecystitis we can think of, ma'am. Any intestinal
Absolutely.
obstructions, perforations, we can think. Any aortic dissections, we can.
Okay, so I was talking about your history and physical examination. So what would be anything would be different in the physical examination with, if you are saying intestinal obstruction and all of that? Just go back to your physical examination. So what would be there would be something different, right? The abdomen would,
The guarding and rigidity will be present.
at least some abdominal distension will be
Yes.
there if there is intestinal obstruction,
Yes, ma'am.
isn't it?
Yes.
So whenever you present, now we know that you've already seen this case, you have treated this case, but whenever you present, so stepwise fashion, depending upon the history and physical examination, even before the investigations, you have to put those things together, right?
Yes, ma'am.
So those things you will have to keep in mind. Yes, acute cholecystitis can be one of your differential diagnosis. It could be an acute severe gastritis as well,
Yes,
isn't it?
ma'am.
So those kind of things. Could it be something non-abdominal? Something
Myocardial infarction.
absolutely. This patient could have an acute MI. Sometimes, especially if they are diabetic, they can have an atypical kind of presentation. So those things will have to be in your differential. If this patient had intestinal obstruction, the physical findings would have been a bit different. Okay? Okay.
So, thank you, Saswati. So,
Sorry. Yeah.
no.
Dr.
So,
Maneendra.
as rightly pointed out by Madam, so you should have a diagnosis, working diagnosis, even before your labs are available with you. Okay. So whenever you are presenting after this clinical presentation, you just present saying that these were my differentials, which I was anticipating. Then I have admitted the patient in the ward, and then these were the reports which came. Okay. So next slide.
Just to add on, Maneendra
Sir,
and
sir.
Kiran. So
Yes.
I think if you elaborate the history and clinical examination findings a bit more, it will narrow down your differential diagnosis. It's not pertaining to this particular case, but any case for that matter. One. Second thing, your history and clinical examination should give you idea about how much is the severity of any particular illness that you are going to say. So since you are saying that this patient has got a or typical chest pain which is radiating to the back, I think you need to be very clear about what is going to be life threatening.
Yes.
So life threatening, only 2-3 conditions are going to be there. So because if you wait for the lab investigations, you wait for the values to come back, then by the time you diagnose and want to act on it, it will be too late, especially in aortic dissection,
Yes.
especially in a STEMI or ACS, like acute coronary syndrome, especially with a pneumothorax, if I have to say that way, or especially with a Boer-Hart syndrome with an alcoholic background. We should be able to delineate what is going to be life-threatening in next few minutes to few hours before you get all this lab and investigation. That's applicable to all cases for that matter. So I'm happy for you to go ahead. Let's see from there, okay?
So after 1 day of admission in the ward, he had sudden clinical deterioration. That's why he was got
Uh,
shifted to ICU.
Sorry. Actually, if you say there is a sudden events are sudden events that don't happen. Okay, there is something that we are going to miss. Did you look after this case right from the beginning, or you got all this information based on the notes that has been written?
From ICU admission, we have seen, sir, before a ward, we got shifted the patient after clinical deterioration to the ICU, sir.
I think it is quite common for us to present saying that everything happens suddenly, sudden onset of shortness of breath, sudden onset of chest pain, sudden onset of neurological deterioration. But I think patient gives enough time for you to, enough warning signs. So let's go ahead and do that.
On arrival to ICU, patient was tachypneic. His saturation was around 91% on room air. On auscultation, there were bilateral crepes, and he had hypotension with blood pressure around 80 by 50 mm of Hg. And bedside focus was showing IVC around 1.2 centimeters with more than 50% of collapsibility. And there was bilateral B profile in the lungs. So we started with fluid resuscitation. initially we have given 1 liter fluid bolus followed by started infusion, and we started norepinephrine infusion at the rate of 5 micrograms per minute. We inserted central line and arterial line and intubated in view of worsening SOB and hypoxia. We inserted RT and started feeds at the rate of 30 ml per hour. We started analgesics and started him on meropenem 1 gram IV TAD as per primary. His lab values were around, he had a fever of around 101 degree Fahrenheit. And
can we stop here? Okay, let's go back to the previous slide. I think when you're because you're presenting the case that you are aware that it is a pancreatitis, maybe I think it's worthwhile going through saying that, okay, the clinical severity is such that the patient has deteriorated within 24 hours. Okay, is that correct?
Yes, sir.
Yes, and he came in a distress to the extent that he is having multi-organ failure, hemodynamic as well as respiratory bare minimum, which requires an organ support and immediate and emergent interventions. So maybe in the ward, this patient may be deteriorating and is giving enough warning signs, but those warning signs are either not recognized or not addressed to the extent that the patient comes in extremes to the ICU. It looks like that it has come to extremes. Okay. Now,
this was a medical.
While the case presentation is going on, I'm happy if you're okay with that, in the sense that we might interrupt you just to give an overview how you're going to have your thought process aligned for you to get an better understanding, how do I put it, better understanding as well as better outcome as the case goes by. At the end of the day, this case is acute pancreatitis, but how did you manage this patient? What extra could have been done to anticipate or prevent certain preventable problems? That's what we will do. Okay. Now, looking at it, looks like that this patient has deteriorated. What are the signs that this patient? What are the signs or clinical parameters which will give you idea saying that this patient is very sick? Like we talk about the clinical severity, isn't it? So the severity scorings are there. So as you keep on presenting, try to address it, saying that this patient is so severe. You okay with that?
Yes, sir.
Yeah. So, all right. So with this slide, what do you think? The patient is very sick, obviously, isn't it?
Yes, sir.
Yeah. So are you aware of any severity indexes or severity scoring systems?
Yes. BISAP.
Yeah.
BISAP scoring
Sorry?
BISAP scoring system with bedside index for severity of acute pancreatitis. It will show burn of more than 20 and impaired mental status, SIRS response age more than 50 years, and pleural effusion. If it is 0 to 2, it will be low risk, and if it is more than 3, it will be high mortality, sir.
Okay. So I think that these are all prediction models. So basically, if you look at whatever index scale, old Ramses to Apaches to BISAP to whatever you want to put it, so they give you a severity index. So multi-system parameters are involved, and when they get involved, the more parameters are involved, the more sicker will be there. Yes. And if they are more sicker, they are likely to land up more mortality. That's what it looks like. That it's good. It's good. Any other severity indexes that you are aware?
Ransons will be there, sir. Glasgow Image score. So far scores we can use Apache scoring systems. And index.
No, that comes later, isn't it?
Yes, sir.
Yeah. So based on the clinical situation, you know that this patient is sick, obviously, severe, and the mortality risk is how much is there?
BISAP score, it's more than 2, sir. It's more than high mortality was there, sir.
Okay. So there is a prediction model, isn't it? I don't remember the exact value, but maybe I think for the students and everyone to go through it, that will be reasonable. Now, while we are going through this history, now the another important thing is there. Now, pancreatitis management is most of the time it is supportive, isn't it?
Yes, sir.
Yeah. But there are few certain situations where the etiology demands emergency interventions.
Yes, sir.
Okay. So going through the history, so what are the other causes of pancreatitis apart from the alcohol that you mentioned?
Gallstones, sir.
Mm-hmm.
Gallstones, any autoimmune disorders, drugs like azathioprine, digoxin, and
hypertriglyceridemia, hypercalcemia,
Mm-hmm.
mm,
Anything else?
idiopathic,
malignancies.
Idiopathic and
autoimmune diseases.
yeah. Okay, out of these particular etiologies, I think there are a couple of more etiologies that you can delineate, definitely. So post-procedure pancreatitis, post-ERP pancreatitis, those are probably more common than the autoimmune processes, but irrespective, congenital malformations and other things. Out of these etiologies, which etiology warrants emergency intervention to decrease the severity and to give a good prognosis?
If the patient has acute gallbladder obstruction leading to cholangitis, we need to do ERCP immediately within 24 hours to remove the stones.
Yeah, remove or bypass it. Yeah. Anything else? Okay, so we understand based on the history that this patient had alcohol-induced pancreatitis, and patient has deteriorated within 24 hours, landing up in ICU post-med call, requiring multi-organ support, and he's getting sicker and sicker. The way it looks like that. Yes. Hello?
Yes, sir.
Yeah.
Yes, sir.
And yeah, thank you. Okay. Madam, you have something to add?
No, I think Dr. Sachin had indicated something else also. Apart from resuscitation, you already mentioned about if there is cholangitis, then there is an emergent intervention in terms of ERCP. You mentioned one of the other etiologies that might need something a little bit different from the conventional, apart from resuscitation, something you've already mentioned the etiology.
Hypertriglyceridemia.
Yeah, so what would be the
exchange we can?
Yeah, so at that this patient, how much triglyceride is alarming?
More than 1000 milligram per
More
deciliter.
than 500 should already give you an indication that could be, but more than 1000, of course, is something which will need immediate intervention. Okay, so go ahead, please.
So his lab parameters were around HB hemoglobin around 16 with total counts of 15,000. His BUN has raised to 34 with serum creat of 1.9. He had procal of 6.19. And his ABG values are showing lactic acidosis with the lactates around 7.93 with pH of 7.29 and bicarbs of 11 with base excess of -12. X-ray abdomen, there was no abnormality detected, and ultrasound abdomen, there was no collections, and we have sent blood cultures because of elevated fever spikes, and procal was raised more than 6.
Okay. Why did you tell in this patient?
Sir?
What was the reason for doing a procalcitonin, and what was the reason for meropenem?
So he had, procalcitonin more than 3.5, we can start off antibiotics with these patients. And he had fever spikes also. Maybe it's a surge response, but elevated procal, we can suspect bacterial infections.
Okay. Are you aware, like I'm just sidestepping, but are you aware of non-infective reasons for procalcitonin to be raised? Yeah. What are those reasons? Non-bacterial infections. All right, you can look into that one later. Okay, and so based on this investigations, what's your impression?
So he was in surge response, and third space losses are happening. He's dehydrated with the elevated lactates.
Okay, and how are you going?
Is happening because of a hypovolemic state.
Sure. And how are you going to resuscitate? What's your? Did you finish the day one, or you are still
Yes.
lights ahead?
And this is why this is day 2, sir. In ICU, it is the day 1.
Okay, you go ahead with that.
So here, so are you justified in starting carbapenems directly? Is carbapenem the only drug of choice for pancreatitis? What is your
we are suspecting
take, Indra and Pratyusha?
We can use.
So see, this is a straightforward patient who came from the community. It
Yes.
is not that he has had any recurrent hospital admissions as per your history. So why? Okay, you might be saying the lactate is high, patient is in shock, procal is high, even though procal only has negative predictive value. So are you justified in starting a carbapenem directly, or what is the rationale?
If we are suspecting infected pancreatitis, carbapenems have effective penetration.
I have a point over here. He is on day 2. In fact, at the most, he's of day 3 of illness.
Yes, ma'am.
So, do you think infected pancreatitis happens so quickly?
No, ma'am.
So, when does it happen?
More than day 4. After peaks at day 14, ma'am. It's very less.
Yeah, it's usually, I mean, even necrosis also starts happening only after 72 to 96 hours.
Yeah.
So when we're talking about infections, if we are suspecting that there could be an extra pancreatic infection somewhere else, isn't it?
Yes,
So
ma'am.
then maybe you have a rationale of starting antibiotics. You might say, yes, this patient is in shock, so by the time we get the cultures, but you yourself said that the patient is hypovolemic, there is third space losses, there is increased hematocrit, there is increased creatinine. So those itself could also account for all this hypotension and things like that, right?
Yes, ma'am.
So when you say that the reason you have started antibiotics is infection, that will be not acceptable. If you start an antibiotic and you think that if you have to justify it, you have to consider that there could be an extra pancreatic source of infection which you are suspecting. And you have to have a rationale for that, right?
Yes, ma'am.
So very unusual. I mean, it won't be acceptable if you say that you are using it for pancreatitis. Okay.
So,
And
so
also
as right.
fluids, yeah.
Yeah,
Dr.
please go ahead,
Maneendra,
ma'am.
hand over
No,
to
no,
you.
please go ahead, ma'am.
So regarding fluids, so what is the usual thing? How you're going to, Dr. Sachin was also asking you, what would be your guide for resuscitation?
So, we'll monitor hematocrit and burn and urine output, ma'am. Urine output more than 0.5 ml per kg per hour, and we'll maintain hematocrit around 35 to 45. And there should be decrease in burn in the first 24 hours. And his heart rate also should come down with the fluid resuscitation.
See, hematocrit you will maximum be able to monitor, you'll probably monitor once a day.
Yes,
But are we going to wait till the next day to see are we resuscitating the patient adequately or not? Do we do that on the bedside?
No.
What are your endpoints of resuscitation, or how do you think that your patient is doing better with fluids, or do you need to give more fluids, or should you step back on the fluids? So how you must be doing it on a day-to-day basis. So regarding this patient, what would be your rate of fluid administration? How are you going to monitor responsiveness or tolerance? So those things will be important, right?
Yes, ma'am.
Yeah. So how are you going to do that?
Urine output will monitor, ma'am. Lactates we can monitor, and heart rate, how he respond, heart rate we can see, and any capillary. Heartbeat.
Okay, heart rate you can see, you can monitor the urine output, you'll monitor the blood pressure, you will monitor the lactates. But you said that you landed up ventilating this patient, right?
Ultrasound.
Right? And you said B lines started appearing, if I'm not mistaken.
Yes, ma'am.
So, why do you think B lines could appear in this particular patient? Why did the patient get hypoxic?
Third
What could be the
capillary leak can, because of capillary leak, third space losses can happen, ma'am. Might be the patient had pulmonary edema, leading to hypoxia.
So then will we stop fluids to this patient if the patient is developing pulmonary edema?
No, ma'am. We don't do aggressive fluid resuscitation. We'll moderate fluid resuscitation.
So what will you tell your nurses? How much moderate?
We'll give 10 ml per kg fluid bolus followed by 3 ml per kg per hour infusion, ma'am. We'll assess on a regular basis every second hourly. we'll see lung profile and everything. Accordingly, we'll change the fluid resuscitation.
Okay, this patient is ventilated.
Yes, ma'am.
How are you going to assess for? Because you're going to give fluids only if the patient is responsive to fluids, right? Right? Because you've started NORAD.
Mm-hmm.
You will continue to give fluids if you think the patient is going to benefit from fluids. So in this patient, how can you assess fluid responsiveness? You said IVC. In a patient with pancreatitis, how easy will it be to see the IVC? Abdomen, etc., might start getting distended. So IVC itself might be a bit difficult to assess in this particular patient. So if the patient is intubated, not only for pancreatitis, what could be the other ways of assessing for fluid responsiveness?
Urine output.
Dr. Indra and Pratyusha, please be a little loud. That is the request from all the audiences.
Urine
output you mentioned, blood pressure you mentioned. Say the urine output, this patient is 80 kgs. Say, I'm just telling you, the urine output is around 30 ml per hour. You said you wanted a urine output of more than 0.5 ml per kg per hour. Say it is borderline, it's not great. The heart rate is still around 120, 130. So apart from what you're already doing, heart rate, blood pressure, urine output, anything else you can do? This patient is requiring NORAD. Would you put in an arterial line in this patient? If the NORAD requirement is increasing, you're having to do ABGs, etc.
Yes, ma'am.
Yes?
Yes, ma'am.
So can you do something with the arterial tracing?
Yeah.
For fluid responsiveness?
Yes.
Static and dynamic variables.
Stroke volume variations we can.
Yeah, at least your pulse pressure variation and stroke volume variation. Of course, you will need a monitoring of a cardiac output.
Yes,
but at least pulse pressure variation you can do with an arterial line.
Yes, ma'am.
Yes, ma'am.
Isn't it?
Yes, ma'am.
Okay. And what could be the other? Okay, so please go ahead. I think otherwise we will not finish. Please go ahead. Yeah.
I think that's a good point. Primarily, pancreatitis patient will have relative fluid deficiency, and the whatever guidance you are going to use it should have an endpoint, and endpoint should be acceptable to you. So the reason I'm using that acceptability, you should be looking at the pros and cons of continuing or ongoing fluid resuscitation without compromising other organ functions. So otherwise, it's not too far that you flood the lungs, the capillary leak, you get land up with a pulmonary edema, you will develop intra-abdominal hypertension, venous congestion will happen, renal congestion will happen, you will get fluid everywhere, hemodilution will happen. So all these things can happen. So you have to be careful in what you are going to do. I think most of the time in practical way, if you look at all our ICU patients, or especially pancreatitis patient, they are over resuscitated rather than under resuscitated. So all this goal-directed therapy is not to err on the over resuscitation side. Just be careful with that thing. Thank you. Let's go ahead with that.
Yes, sir. So in day 2 after fluid resuscitation, still his hemoglobin was around 15 with the total counts rise to 20,000 with the platelets around 1,73,000. His creat also has gone up with 1.9 to 2, and his BUN has rise to 56 from 35, and his he's having continuous fever spikes around 103 Fahrenheit, and his ABG is showing persistent lactic acidosis more than 12 at the base excess of 14 with bicarb of 13 and pH of 7.19. CT abdomen with contrast was done. It was showing suggestive of pancreatic and peripancreatic collections with CT severity index of 5/10.
Okay. Let's hold on there. So what are the imaging modalities that you will choose, and what time frame you will choose, and what are the advantages and the disadvantages of individual modality for pancreatitis?
Ultrasound abdomen can be done for all the patients, sir.
And the reason?
Non-invasive.
It's a simple and non-invasive procedure. We can
cost effective.
Okay, one is it's bedside. Second one,
we can do it, but I mean, like there will be no interruption of resuscitation. Also, we can continue with the.
it avoids the transport implication.
Yes.
Yeah, implications associated with that. Then third cause. Third reason.
With contrast and all that, AK can worsen.
Okay. CT with the contrast, fine. Another reason.
Cost.
Yeah, cost effective. But I think primarily you do it because you want to look at immediate treatable causes of pancreatitis, like gallstones, the CBD dilatation, cholangitis, or extra pancreatic tissue, which is inflamed. You can see it on ultrasound. That's the reason you do it at the bedside. That's the first modality of choice, isn't it?
Yes.
And the second modality is CT with a contrast. When do you do that and why do you do that?
After 48 to 72 hours, we can do it, sir. If we have any diagnostic dilemma, we can do it. Or if the patient is not responding with all fluid resuscitation and all, then we can go ahead and do CT abdomen to assess the severity.
Severity, okay. And the time frame?
After 48 to 72 hours.
70 to 96 hours. But if do you do a sequential CT subsequently?
Sir?
Sequential
Is there
CT.
any role of sequential?
No, sir.
No. Okay. All right. And any other imaging modalities that you are aware of that's useful in pancreatitis?
We can also do MRI, sir.
MRI of what?
To look for gallstones.
Oh, you are talking about MRCP.
Yeah.
Is that correct?
Yes.
Yeah. And what's the advantage of MRCP over CT or ultrasound?
Contrast allergy.
No radiation,
contrast allergy.
And there will be no risk of pancreatitis. Post ERCP, there are chances of pancreatitis.
I think it's more of a generic that what you're talking, isn't it? Just a very specific, pushing the patient for MRCP, staying in the MRI room in a sick, unstable situation for half an hour to 45 minutes. You should be super selective in choosing MRCP and in which condition you will choose it. Now, my question is very specific to pancreatitis, not generic. So what is not picked up on ultrasound or CT that you want to pick up on MRCP, which will change your management?
Any obstructive gallstone.
Okay. And? All right. So something to think about. So we won't give that. Any other imaging modality?
Endoscopic ultrasound.
That's good. Fantastic. Okay. So that's one that's commonly it's been done, isn't it?
Yes, sir.
Something or the other, some sort of imaging you'll be doing apart from the bedside chest X-rays, bedside ultrasound, what you have as a focus assessment on a daily basis. Okay. What sort of complication would you expect on day 2?
That's third spacing losses can be because
I'm just going to go through little by little, otherwise we won't have time. So tell me, what are the complications that you will see and what is the time frame for those complications that you think that on day 2 you should be aware of?
Bilateral effusions,
Okay.
ascites, pulmonary edema, decreased urine outputs.
That's a renal failure. Sorry?
AK, acute kidney injury.
Yeah. Anything else? So how do you divide the complications? So complications related to pancreatitis, one is an acute, there is a subacute phase, and there is a chronic, and maybe I think in the long term. Okay. And then the other way of classifying the pancreatic complications are like loco-regional complications that happens in and around the pancreas, and then maybe a systemic or distant complications. So you want to delineate what do you expect in first 48 hours?
Peripancreatic fluid collections can happen, sir.
Okay. So you already have got, this looks like that this patient has got a ARDS, isn't it?
Yes, sir.
Yeah, okay. And this patient has got a hemodynamic instability. And I suspect this patient has got a distended abdomen as well.
Abdominal compartment syndrome.
Yeah, abdominal compartment syndrome. Okay, yeah. So we can go into that detail, intra-abdominal hypertension, what level you call it, and intra-abdominal compartment syndrome, that is ICS, when do you call it? But if you say that organ dysfunction is there and intra-abdominal pressures you are suspecting to be high, then it becomes a syndrome, isn't it? Okay. Anything else? So a dynamic ileus or subacute bowel obstruction. So that's a quite common thing. So what are the complications that you are expecting at this present moment?
ARDS can happen. ARDS, AK.
So this patient already has, isn't it?
Yes.
Yeah. Then
Local complications.
local complication. It's too early, but yeah, that's fine. Yeah. Okay. And would you consider for surgery at this present moment? There's no surgical intervention, I suspect.
No, sir.
Okay, let's go ahead with that.
Okay, just 1 minute. Depending upon how you are at the present moment, how would you classify it into as per the severity? Mild, moderate, or severe?
Severe acute pancreatitis, ma'am.
Why?
He had
What is the criteria?
this revised Atlanta classification we can use, ma'am. It was mild, moderate, and severe. In mild, there will be no local complications and there will be no organ failure. In moderate, there will be transient organ failure for less than 48 hours with local complications. And severe, there will be persistent organ failure for more than 48 hours.
Okay, yeah, right. Please go ahead.
So his hemodynamics were borderline with the NORAD requirement, and his fluid assessment still the IVC is collapsing and he is responding to fluid boluses. So we continued with maintenance fluids, and he was not. There was residual feeds, so we started him on instead of NG, we started him on nasogenital feeds.
Sorry, and Pratisha. So when you say IVC is collapsing in an intubated patient, I think that's not a marker for fluid assessment. Collapsibility is not a marker in an intubated patient. Okay, positive pressure ventilation. Please don't mention that.
Yes.
The other thing is that if you say there's a maintenance fluid is required, there are enough articles or enough data is there which shows that maintenance fluid will result into cumulative fluid positive fluid balance, which is proven to be unnecessary. Okay,
yes.
sorry.
So on day 3 to day 5, his hemodynamics were stabilized, but he had minimal peripheral edema, and his urine output was maintained. And whenever we stop sedation, he's becoming tachypneic, like maybe withdrawal or difficulty in weaning. From day 6 to day 9, he had a sudden increase in peak airway pressures associated with oliguria. On examination, the abdomen was distended, and we measured intra-abdominal pressure. It was showing around 20 mm of Hg. So we withholded IB fluids, and we have done bedside scan, which was showing free fluid in the abdomen. And we started him on muscle relaxants, and we started decompressing him through NJ tube, and we used diuretics, and we continued monitoring his intra-abdominal pressure every 4th hourly. So from after.
So how do you diagnose intra-abdominal hypertension?
When pressure is more than 12 mm Hg, ma'am, it is intra-abdominal hypertension. When pressure is
How do you measure?
By using Cron's method, ma'am. It's an indirect method. With the indirect method, we'll clamp the outlet of the Foley's and we'll keep the patient in supine position, and we'll every time we'll measure this thing. We need to keep constant volume in the bladder, so we'll install 15 to around 20 ml of fluid, and we'll keep the transducer at the iliac crest level, and we'll zero it, and we'll measure it. We'll measure the abdominal pressure, ma'am.
So supine position, any other things you need to take care of while you measure?
Like constant, the transducer position should be at the iliac crest level, and constant volume should be maintained whenever we do that measurement.
Yeah, so how much volume? Is it 15 or is it 30?
15 to 20 ml we can.
Are you sure?
Oh, yes, ma'am.
Please go back and check it.
Okay.
Yeah. And then you should make sure that the patient is not, struggling. Why? Because if the patient is in a lot of pain or the patient is restless, can it hamper the measurement of the intra-abdominal pressure?
Yes, ma'am.
Yes, ma'am.
Why?
When he moves, this abdominal pressure will rise, ma'am. Whenever we
Yeah,
do
because
position also.
it's apart from the position also, if the patient is constricting the abdominal wall because of whatever reason, so that itself can also hamper your monitoring of the intra-abdominal pressure. Okay. And like Dr. Sachin was mentioning, that these maintenance fluids, everything actually ultimately builds up to intra-abdominal hypertension. So you all, again, when the creatinine was rising earlier, apart from fluid resuscitation per se, we can even start thinking about that at that point itself, because we are now already on day 6 to day 9, right?
Yes.
So this patient might be like significantly, cumulative fluid balance might be quite significant. So that is the reason after the initial resuscitation phase, every day look at the cumulative fluid balance, because maintenance fluids, nutrition, sedation, everything put together will add to the fluid creep. So that is the reason sometimes you will need to prevent. You also said diuretics.
Mm-hmm.
How did you decide to use diuretics, and what was the patient's creatinine? So how?
Creat was around 2.9, ma'am. We thought of maintaining negative balance, so we started him on dose of diuretics.
And was he off vasopressors by now?
Yes, ma'am.
Okay. And another thing is, you mentioned that the intra-abdominal pressure was how much?
20 mm of Hg.
20. Okay. Anything else? What are the other ways of managing this intra-abdominal hypertension? So would you straight away use diuretics, or say if this patient was hemodynamically unstable, the vasopressor requirement is already there. So would you use diuretic, or would you do some other things also? What are the other things you can do to handle this intra-abdominal hypertension?
To improve the abdominal compliance, we can use muscle relaxant, proper sedation. We can use prokinetics, and we can decompress the intraluminal contents by nasogastric or rectal decompression, and we can remove the intra-abdominal contents. If any fluid was there, we can do tapping, and we need to keep the head and avoid the head end up positions.
Say you have done all of that, still the intra-abdominal pressure is high.
We can we can go for surgical.
The patient is still not ready for surgery. We are just on day 10.
Okay.
Can you do something with ultimately, what are we trying to do? We have done everything to lower the intra-abdominal pressure. What are we trying to do by lowering the intra-abdominal pressure?
Abdominal perfusion pressure.
Exactly. So anything else you can do if after all
Mean pressure we can increase.
Yeah, so you can titrate your vasopressors in order to maintain the
mean arterial pressure.
Mean arterial pressure. And how much pressure would you target?
Up to less than 60 mm of Hg.
Less than?
More than 60 mm of Hg.
Anything with this intra-abdominal 20 millimeters of mercury? How much would you want a map? Normally we want a map even otherwise more than 65. So?
More than 75 we can.
So it needs to be higher. It needs to be 2 into IAP plus whatever, then that much amount of pressure. So abdominal perfusion pressure should be at least more than 50 to 60, at least the perfusion pressure. So your MAP needs to be much higher in this particular patient. Okay, go ahead, please.
So, patient abdominal compartment syndrome improved with medical management, and his peak airway pressures got settled, and his urine output increased to more than 0.5 ml per kg per hour. From day 11 to 14, patient shock has improved off vasopressor support. We started him on weaning trial, which he tolerated well and got extubated to face mask. After 24 hours of monitoring, we shifted him to ward with stable vitals. Back on day 17, he got shifted back to ICU in view of a high-grade fevers associated with hypotension. His heart rate was around 90 to 95 per minute, and he had low BP with around 90/60 with NORAD requirement. We have repeated CT abdomen with contrast, which was showing gas in a peripancreatic collection. Surgical gastroenterology team reviewed and have done CT guided pigtail insertion, and the sample was sent for cultures. We have escalated antibiotics from meropenem to avibactam and aztreonam. Later on, cultures were suggestive of pan-sensitive E. coli. We de-escalated antibiotics accordingly, and the patient got clinical improved around 18 to 20 a day of admission, and he got shifted to ward.
Okay, if I have to ask you, Indra and Pratisha, would you have done anything different than what has been done so far as a global overview of this case management?
We might have abdominal compartment syndrome. We might have suspected earlier than delayed.
Yeah, and anything else? Yeah, that's a good point. I think certain component of abdominal compartment syndrome is a preventable aspect.
Yes.
Yeah, like right from the fluid to nutrition to aerodynamic ileus to nasogastric aspirations to too many things that what can do. Certain components of intra-abdominal compartment syndrome could have been prevented. That's one. Second one.
Fluid resuscitation we might.
Okay, yeah, that's part of the process. Anything else?
Antibiotics earlier we have started directly meropenem. We can start with the.
I think that's kind of forced, isn't it? The primary wanted it. That's why
Yes.
it was. You mentioned that. I understand that thing. Okay. Anything else? Okay, so I'll come back to it. I think there are few caveats in this case management which hasn't been explored to the extent that it deserves. So the first is let's see. Okay, what are the indications for surgical management? In which cases you think that the surgery is indicated?
Infected necrotic pancreatitis, we can do surgery for post stabilization. If the patient is clinically unstable, we need to do it on emergency basis. And
okay.
Others acute cholangitis, cholecystitis we can.
Okay, that's borderline. That's because the goal is not to disturb the pancreatic tissue as much as possible. Okay, you don't want to go ahead and do the operation when the risk and benefit, the risk is more versus the benefit. That's why minimally invasive procedure, be it surgical or endoscopic or intervention based, whatever is there. The goal of therapy in the long term or short term. That's one. But in couple of cases, you need to open up. What are those cases?
Yes, abdominal compartment syndrome.
Yes, that's good. Any other?
Mesenteric ischemias, perforations.
Yeah, that's a general indication, but specific to pancreatitis. Okay, so coming back to it, what are the complications within the abdomen related to pancreatitis? Within the
peripancreatic fluid collections with pseudocytic, splenic and portal vein thrombosis, gastric outlet obstructions,
ileus.
Ileus, yeah. Any other things? No, the patient can bleed to death.
Aneurysmal ruptures.
Which aneurysm?
Duodenal.
No, it's an arterial aneurysm. Which artery? Which is very specific. In which condition you have to open up the patient or go for interventional radiology? Splenic artery, isn't it?
Yeah.
The splenic vessels are running through the bed of pancreas. especially the tail and body, not the head. If there's a splenic artery aneurysm and they bleed, then you have to open up. And that doesn't happen immediately. That happens in a subsequent, maybe 2 to 4 weeks down the line from that point of view. Okay. Anything else that you haven't mentioned about this patient's management? Like, in your ICU, you follow this mnemonic for all patient management, fast hug, me, BID kind of thing?
Yes.
Yeah. So first is what?
Feed.
Yeah. So is that an important aspect of this patient management?
Yes, sir.
Okay. So disease specific nutrition goal for this patient? This is specific in the sense, not the generic one for the pancreatitis.
This is a high catabolic state, so we'll use high proteins and low calorie diet, sir.
Anything else?
No.
So no, I'm asking whether the enteral feeds versus the TPN, because this patient was not tolerant, isn't it? So
enteral feeds will start.
Okay, enteral, post pyloric, or whichever route you can feeds, that is the best one compared to the TPN.
Yes, sir.
Or co-nutrition with the TPN or supplementation, that can be considered. And sometimes lipid-free nutrition can be considered. Okay, and what is that one? Is there any role of immunonutrition? I think there is a lot of talks going on, isn't it?
Yes,
That question will be asked. Your primary will come and say that, okay, we want to this particular brand is there, which is going to provide this kind of nutritional benefit. Why not use it?
There is no role for immunonutrition, sir, but glutamine, like recent trials has shown some benefit with glutamine.
Yeah, so those questions will be coming to you every now and then. I think overall, if you look at it, nutrition goal, if you meet via enteral route, and maybe partial supplementation in between when the goals are not met with the TPN, and not going ahead with too much of nutritional supplementation in terms of immunonutrition is a reasonable choice. Okay?
So more than immunonutrition, we get more requests for immunomodulators, Sepsivac.
Yeah.
I guess everyone wants a quick relief or quick change in the parameters, and whatever works quickly, that's considered to be the best one, which probably not true in the short term and long term. That's my take on that, but yeah, open for suggestions.
So when this patient came back with fever and hypotension, so what could be your differential diagnosis? It came back on post 15 days almost, right?
Yes, ma'am.
So what are the things you need to think about? We know this is pancreatitis. We know this is a case presentation. But when a patient is coming back to the ward, so from the ward back to the ICU or from the HDU back to the ICU, so what could be the possible causes of fever and hypotension?
Secondary bacterial infections.
So where? Can it be only in the pancreas or it could be elsewhere?
Urinary tract infections can be
lung.
Exactly. The patient might be having a catheter now for over 2 weeks, right? The patient might be having a central venous access. So you need to think about all of those things. And like it has already been discussed, like you said, that acute peripancreatic fluid collections, in the first 4 weeks, the collections are a little bit different. Now, most probably you will do a repeat imaging. And if there is an encapsulated collection at this stage, what is it called?
walled off necrosis.
Right. So it could be either a walled off necrosis, or if it was a say it was a non-necrotizing pancreatitis or interstitial edematous pancreatitis, and if there is an encapsulated collection, what would you call that?
Pseudocyst.
Yeah. So if the patient is presenting with fever and all of those things, so you need to think about walled off necrosis. And open surgery, please, like it has already been mentioned, it should be minimally invasive at least till week 4, until and unless you are, you have no other option left, or there is an aneurysm which is bleeding or something like that. should try to postpone the surgical conventional necrosectomy, if at all required, till more than 4 weeks, as much as possible. Otherwise, the mortality rate is very high. Yeah.
So few questions from the audience, ma'am. So
Yeah.
initially, like I think we have already discussed this, is it pancreatitis or a new sepsis or any other thing like a scrub typhus or an alcoholic hepatitis? So I think Saswati ma'am already told day 3 it is very unlikely for the pancreas to get infected. So we had to look for other infections also. Then what are the guiding points of resuscitation? When you already have a B profile with raised lactates and overt hypotension.
So I think the B profile can be there, even if the patient is developing an ARDS, the lungs could still have a B profile. So at that point in time, like it has already been discussed, you need to be more cautious regarding your fluid resuscitation. So you should see by giving fluids if you're benefiting the patient or not, or if the B lines are worsening or not. So those kind of things need to be very important. You need to really start thinking about what you should do about the maintenance fluids, because the B lines can increase if we are pushing the patient into fluid overload, or it could be the ARDS worsening. So both the fluid responsiveness, you need to be now more focused. So you need to use either a pulse pressure, stroke volume variation, or we need to be very clinical in terms of our fluid management. I think that will be very important, but that does not mean in pancreatitis, just because the B profile is worsening, you stop fluids. So that is something which will be important.
So once the patient is intubated, however, even if there is a little bit of edema, probably we can manage it with a PEEP. So B profile is not a real risk or really contraindication for resuscitation, right?
Yes.
Like rightly said. The next question, ulinastatin octreotide in pancreatitis, any role? Sir, Sachin sir, you want to take this?
I haven't used it, and I don't propagate of use it. There are few proponents of it with a strong belief that it works magically, which I don't believe.
I am not unable to understand. Any role of Perfenix in acute pancreatitis?
Not heard about that being used. I haven't used it.
No.
So
What is the cause of pancreatitis in this case? I think this is pretty straightforward.
Yeah, alcohol.
can I just add on to it? I think
Sir.
We are talking about fluid resuscitation most of time with most of the cases.
Sir.
Whatever parameters that you are following, the dynamic variables, the static variables, I think it is primarily been devised to avoid harm with giving more fluid. Fluid is a drug at the end of the day. So it has its own side effect. All these dynamic variables are giving you an option of how much you can give, and beyond certain limit, if you give, it will cause more harm. So it is more of a safeguarding patient from us doing more than what is necessary. It doesn't guide me as a therapy saying that, okay, my SVV is 15 and I should give it. No, it doesn't mean that thing. It just give me an idea saying that if the patient requires fluid, it is safe for me to give it. Not necessary that value is 15, value is 20 SVV or PPV is 15, you give it. That doesn't give you that guidance. It just avoids the harm. So something that we need to be aware of, that value does not equate to give fluids. It just gives an additional safety from that point of view.
So I think it's 8, sir. So any closing comments, Sachin sir?
Just a last comment. I think we missed this fast hug, me BID. It's not a mnemonic as a mnemonic, but I think it gives an idea about how we are going to look after a particular patient in a more holistic way. Like we are talking about F as in feeding, and feeding has to be directed to that particular patient's demand. A as an analgesic, that should be directed to what is there. In pancreatitis patient, their pain requirement will be very high. What is the medication that you have? It is going to be changing every day. Sometimes you can use paracetamol without causing hepatotoxicity. You have to use some other drugs, including regional anesthesia. So that options that you have to explore as the case demands or dictates. Same thing about the sedation, same thing about thromboprophylaxis. These patients are more prone for DVTs, PEs. You have got so many invasive lines. Patient develops splenic vein thrombus, portal vein thrombus, peripancreatic, this collection, that collection. You put an IgV, there is thrombus. So even the sedation as well. You use too much of propofol, which has got the triglycerides, and then you choose, oh no. Sometimes you can be very pedantic in saying that no, I don't want to use propofol. I want to use something else. Even ketamine can be used. There are plenty of options if you follow this mnemonic and directive therapy based on what the patient's dynamic situation is there. Today, pancreatitis day 1 versus day 25 will be entirely different parameters, but the goals of therapy keep on changing depending on what's the status of it.
Saswati ma'am, any closing comments?
So I think, yes, one thing, I think both of you really presented quite well and went through the whole process and tolerated the onslaught of questions. But just one suggestion to you, don't be focused on, see, this patient has pancreatitis. The patient has not read the chapter on pancreatitis and come, right? So there would be other things which you do on a day-to-day, and I'm sure you're doing it at the bedside. So always think of other things, like always think how much fluid you are going to give, how are you going to assess for fluid responsiveness, when you should stop the fluids, when you should think of other nosocomial infections, if an antibiotic has been given, so you need to have a look at, you said that gas within the pancreatic tissue, right? So that is an indication. So you need to know very clearly what nutrition to give, when you should start nutrition, when you should start the antibiotics, even despite the fact that the primary has asked you to start. When you are presenting it to the examiner, he or she would want to know that whether you are aware that what should have been done at that point in time, okay? And even the complications, like local, regional, early complications, later complications, when should you do a CT? Because you were asked a question that would you do a serial CT? You said no. So that is not acceptable. In a case of pancreatitis, lot of times before the interventions, many CT scans would be done for this particular patient. So you should be prepared to say that if the clinical condition demands or if the clinical condition changes, then we might need to do a repeat imaging. Okay. So just that, I think you presented very well. Thank you.
So thank you, Sachin sir. Sir.
Back to students. Do they have any comments?
Dr. Indra and Dr. Pratyusha, you want to tell something?
No, sir.
Thank you.
So thank you, Sachin sir. Thank you, Saswati ma'am. Thank you, Indra and Pratyusha. So just wanted to close it saying that whenever you are treating a pancreatitis patient, because of all these local systemic complications, always counseling plays a very important role. So the usual thing which I do whenever I get a case of pancreatitis is I tell that it is equivalent to internal burns. So I give them a picture that whenever the patient has burns, it will take at least 1 month to recover. So in this way, this will probably help you in counseling the patients. They'll be able to understand it better. Thank you. Thank you, everyone.
Thank you, sir.
Bye.
Thank you, sir. Thank you, ma'am.